Uh, Good evening to all of you. It's an extreme honor to have all of you for this June Journal Club program. On behalf of FOGSI ICOG, we would like to welcome all of you to this program. It's an honor to have the Vice Chair of ICOG, Dr. Parag Biniwale, with us, the special guest, Dr. Mandakini Meg, all the special guests, Dr. Reena Vani, Dr. Ranjana Khanna, Dr. Kannegi, and Dr. Aparna, who will be joining later. All the presenters from CMC Ludhiana who have prepared so well for the past 1 month with so much of vigor and excitement, I would say. Kavita, is that right? And we are so happy that you're all joining today to talk on 3 important papers like interventions in obstetrics and gynecology, which we assumed were all right, but maybe we proved wrong with such RCT to such coming up. And I would like to welcome all the delegates who are joined in today. Thank you so much. First, I would like to welcome Dr. Parag Biniwale, the Vice Chair of ICOG, to welcome the gathering. Dr. Parag, 1 second. Slides is seen, Kavita. Dr. Parag is a senior ops consultant from Pune.
No, madam. Sharmila, that's okay. That's okay.
1 second.
My identity as Vice Chair of ICOG for this program is good enough.
Yeah, okay.
Thank you.
We would
Good
like
evening.
you to bless the gap.
Yeah, sure. Good evening. I bring greetings from ICOG, the Indian College of OBGYN, which is the academic wing of FOGSI. And it's indeed a pleasure to welcome you all for this month's edition of Journal Club. Dr. Lakshmi Shrikhande, our chairperson, is traveling, and so she could not join today's program. So first of all, welcome all of you. A special welcome to our special guest, past chairperson, Dr. Mandakini Meg. Special thanks to our experts, Dr. Ranjana Khanna, Dr. Reena Vani, Dr. PM Gopinath, Dr. Kannegi, and Dr. Aparna Sridhar, who's joining us at a very odd hour from Los Angeles, the UCLA. And thank you, Dr. Kavita, for making today's program happen. I'm sure there are some interesting papers lined up. Here we also welcome our partners from the Jogi team, Editor-in-Chief, Dr. Geeta Balsarkar, Editor Emeritus, Dr. Suvarna Khadilkar, and of course, I am not going to thank Dr. Charmila, who's the key convener of this program, but she is doing a brilliant work. And Charmila, I hope you continue to do such wonderful activities for ICOG. So once again, on behalf of all the office bearers, I welcome you all. And let's proceed with the program. Thank you.
Thank you so much, Dr. Parag. We'd like to now introduce the special guest for today, Dr. Mandakini Meg. She doesn't need any introduction because Madam is so well known for all the academic activities she initiated during her period, and which is all continuing now. She was a chairperson of ICOG FOGSI in 2020-21, International Vice President MWIA Central Asia, National Vice President of FOGSI in 2012 and 2013. She has won several awards, and she's been part of the government framework which helped FOGSI in so many work. May I request Dr. Mandakini Meg to say a few words before we start the academic program.
Before Dr. Meg says, just wanted to appraise everybody that the Journal Club of ICOG was started when Dr. Meg was the chairperson during the COVID time, and it was one of the most popular activities at that time. So thank you, Dr. Meg, for initiating this and for being present today.
Yeah. So thank you very much. At the outset, I'd like to thank Lakshmi, Parag, all my team, Charmila, Reena, and everybody present here. Thank you, Charmila, for continuing such a brilliant activity and taking it to the greater heights. So thanks to ICD team. This idea was conceived, as Parag correctly said, because we were all thrown out of gear because of our academic activities. But suddenly I realized the students were complaining that, lack of academic activities in that COVID time. So, and the reading habits and so many things were going downhills. So I conceived this idea, why not to have a journal club so that everybody is involved, students are presenting, and the authors are also present. In our post, this thing which Nirja Batla was the convener at that time, it was on preventive oncology, and we could conduct all 9 sessions of journal club, extremely popular. It was inaugurated on the 9th September 2020 by Dr. C.N. Purandare, Dr. Sanjay Gupte and Dr. Usha Saraya. We have that flyer also, and it has started with a lot of bang, and it continued, and it is going, I think, superb in this regime also. Only thing is that what I want to say, very important to the students and the presenter, the idea was that we have to inculcate reading habits. Also to update yourself with the latest, journal and evidence, which will help you in the evidence-based practices. Also, you develop the, questioning attitude, and indirectly everything helps in the practice. And last but not the least, club. That word was very catchy. So the club, journal club, I like, because there is a the fifth benefit is a social activity. We meet at every level, from the ICOG, students, faculty, office bearer, everybody on one platform, that is a club. So I think with these aims, I have started this with Parag as my secretary, and it is going great guns. And again, congratulations for continuing and making it, further academic excellence. So thank you, Charmila, Parag, Reena, and everyone here for inviting me. Keep me inviting. I feel very much at home when I, come for such activities which were initiated by me, and doing the seed which I have sown is now blooming with the fruits. So thank you again, and all the best to the students for today's program. Thank you, Char.
Thank you so much, ma'am. May I now introduce the coordinator for the program, Dr. Kavita Bhatti. She has worked extremely hard, and I gave her very short notice, but she was able to do such great work by taking such great topics for today. She is the professor and head department of obstetrics and gynecology at Christian Medical College and Hospital, Ludhiana, Punjab. She's affiliated to several committees of FOGSI, and she's written several articles, and her publications have been published in journals and chapters and books, as well as in FOGSI Focus. She's a co-editor of the Current Trends in Labor Management book, peer reviewer for Jogi, JSA FOG, and IJOGR, and the editorial board member for various national journals. And she has won several awards, including the Best Clinical Teacher Award, the Wonder Foxian Award, the Manyata Champion Award, and she's a Manyata Lead Assessor of 2022. And I would also like to welcome the coordinator for today, Dr. Dimple. She's an assistant professor at the Department of Obstetrics and Gynecology at CMC Ludhiana. May I now request Kavita to take over the program, please.
Thank you, Dr. Charmila, for the very kind introduction. And at the outset, I would like to thank ICOG office bearers, Dr. Lakshmi Sri Khande, Madam, and Dr. Parag Binewale for giving us this opportunity to do the journal club for June. And of course, I'm very grateful to Dr. Charmila for including me into this. And my residents are very excited, actually. They have been preparing for quite some time, and they chose the topic, and they are very excited to present and learn also. So my journey in ICOG began during Corona time, when I came to know about Dr. Mandakini Meg. She was the chairperson. Dr. Parag was also there. And every time I would have a webinar, any institutional virtual meeting. So Dr. Parag and Dr. Mandakini Meg always used to give me a push that please take ICOG points. And that is how, because of their guidance, I could get more and more involved in ICOG and FOGSI. So I'm very thankful to them, and I hope they will continue to guide me also in future. And Dr. Charmila, of course, has been a great friend always. And for today's journal club, I would like to say that the journal club we also hold every week in our department. It is a mandatory requisite from the NMC as well as from the university that we have PG seminars and journal club once every week. So my residents, they are doing it every week, and we try to do the latest research. And research, as we know, it also promotes awareness among the students, because they're doing the thesis and they have to complete it within 2-3 years. And not only the awareness about research, but also it promotes evidence-based practice when we do our day-to-day practice in our respective fields. So journal club as such is very important, and my students have been very good in a sense that they take it as a very important educational activity every week. So today we have 3 presenters, and they have really chosen very good topics from very good journals, Lancet, Human Reproduction, and our very own Journal of Obs and Gynae India. So we have the 3 topics. One is on ursodeoxycholic acid, and that is a pictures randomized control trial. And the second one is about septal resection, whether we need to resect a septate uterus, especially in infertility cases. We know that it is required in reproductive early failures. So we will be talking about this. And the third one is ultrasound sliding sign, which is very new, I think, for a prediction of additions in women undergoing repeated cesarean section. So my 3 presenters are from the 2nd year, and one is from the 1st year, and we'll take ahead the program. I will ask Dr. Dimple to introduce the international experts and the national experts also. And I'm very grateful to Dr. Aparna Sridhar for accepting our invitation, and she's joining at a very early, very early morning, and she has to leave for work also. She rang me up in the morning, and she would be able to join a little later. And I'm very thankful to the national experts also. And we are looking forward to much learning, especially my residents. Thank you so much, everyone. And over to Dr. Dimple to introduce the international and national experts. Dr. Dimple, are you there? Dr. Dimple,
Kavita, I think you can go ahead and introduce them. I think she's not joined.
So I will share the screen.
Yeah.
Is my screen visible?
It's visible. It's visible, Kavita.
So today's international expert is Dr. Aparna Sridhar. I think she's very well known and popular in FOGSI. She is associate professor at University of California, Los Angeles. And she is the chair of Contraception Committee, FIGO, chair of FIGO subgroup of ICOG Global Health Committee, member of Scientific Program Committee, FIGO 2023, many research and publications and awards and recognitions. She has teaching and research awards at national and international level, FOGSI Achiever Award in 2022, and ACOG Global Health Award in 2022. So Dr. Aparna will be joining late. And we have Dr. Ranjana Khanna. She is the founder president of ISOBAB Prayagraj 21-23. Ma'am is very well known, ICOG Governing Council member 21 to 23, and organizing chairperson for national and FOGSI conferences, organizing secretary for the National FOGSI Conference, again in 2016. Many awards ma'am has on her credit, and she has been faculty at various national, international conferences, delivered the prestigious orations, and author of many articles and chapters in various books and journals. And she has been the co-convener of FOGSI GCPR guidelines on epilepsy in pregnancy. Next national expert is Dr. Reena Wani, and she's a professor, unit head of HBT Medical College, Dr. R.N. Cooper Hospital, Mumbai. She's the chairperson of FOGSI Perinatology Committee 2015 to 2017, President Mumbai Breastfeeding Promotion Committee, Core Committee FOGSI Violence Against Women Cell. She's the editor, co-editor of many books and textbooks, many chapters and books, 75 publications in journals, and she's been a gold medalist with 5 distinctions, 24 prizes and awards. She's been a convener, invited speaker in many international, national conferences, and she's a PG, UG teacher for DNB and MBBS teacher, and also for MRCOG. She's a WHO certified trainer for adolescent reproductive and sexual health, and Mumbai top docs by Innovation India Today 2010 and 2011. So many recognitions for Dr. Reena Wani. Our next national expert is Dr. P.M. Gopinath. She's the director, he's the director and senior consultant, Institute of OBG and IVF, SRM Institute for Medical Sciences at Chennai. And he's been the past president of Fertility Preservation Society, member of International Fertility Preservation Society, founder president of FOGSI, founder secretary of FSI Tamil Nadu branch, member of ASHRAE, ASRM, IAGE, ISAR, ASRM board certified andrologist. Many achievements, and he's been the icon of the year in South India in 2019 and received the Lifetime Achievement Award by IMATE November 2022. So we welcome you, sir. And our next national expert is, see her name somehow.
Dr. C.V. Kannagi.
Yeah. So she's the director of the Fertility Center, KMCH, and she's a professor SSR, and she's been into ART since 1993, and she's working at Tamarai Fertility Center. She's the COG President Scientific Chair, ISAR in 2016, and of Yuva FOGSI in 2019. Organized many conferences, been an invited speaker at national and international conferences. She has done research on Y chromosome and has authored many books. She's a faculty for DNB program and a chairperson also for organizations as well. So I think we have introduced all the national experts. Dr. Charmila?
Yeah.
So we welcome all the national experts.
The first paper will be presented by who, Kavita? You have to introduce them.
So yes, Dr. Neetika, I think she has joined there and she's presenting on ursodeoxycholic acid versus placebo in women with intrahepatic cholestasis of pregnancy, which is a randomized control trial. And this was published in the Lancet in the issue 1021 in the year 2019. This will be presented by Dr. Neetika. She's a junior resident, MD resident of second year. Dr. Neetika, if you can please share your screen. Make it slideshow, Neetika. Yes.
Good evening, everyone. I am Dr. Nitika from Christian Medical College, Ludhiana, and I'll be presenting a journal club on the topic ursodeoxycholic acid versus placebo in the women with intrahepatic cholestasis of pregnancy, pitches a randomized control trial. Introduction. Intrahepatic cholestasis of pregnancy is the most common liver disorder which is specific to pregnancy. It is characterized by maternal pruritus and increased serum bile acid concentrations, which typically resolve postpartum. There are increased rates of spontaneous and iatrogenic preterm birth, meconium-stained amniotic fluid, and neonatal unit admissions. The rates of stillbirths are found to be increased only for women with peak serum bile acids of more than 100 micromole per deciliters. The actions of ursodeoxycholic acid. The ursodeoxycholic acid acts by increasing the biliary bile acid excretion through upregulation of the hepatic metabolizing enzymes and bile acid transporters. It works by stimulation of impaired hepatocellular secretion by post-transcriptional mechanisms, by stabilizing of the plasma membrane and protection of the cholangiocytes of the biliary epithelium against the cytotoxicity of the bile acids, hepatocyte protection against bile acid-induced apoptosis. Ursodeoxycholic acid mainly has protective action against the bile acid toxic effects. Coming to the study design, the current study was a parallel group double-blind study which was done in multi-centric centers It was a randomized placebo-controlled trial done at 33 hospital maternity units in England and Wales. The individual randomization to ursodeoxycholic acid or placebo group was done using a 1:1 allocation ratio. It was approved by the East of England Essex Research Ethics Committee. The funding of the study was done by National Institute for Health Research Efficacy and Mechanism Evaluation Program and the role of funding source. The funder of the study had no role in the study design, data collection, data analysis, data interpretation, or writing of the report. The corresponding author had full access to all the data in the study and had final responsibility for the decision to submit for the publication. The participants, coming to the inclusion criteria, the inclusion criteria were the women with a diagnosis of intrahepatic cholestasis of pregnancy. The diagnosis was based upon the raised levels of serum bile acids, which was more than 19 micromole per deciliter. And the women between the gestational age of 20 weeks to 40 weeks plus 6 days of gestation on the day of randomization, singleton or twin pregnancy with no known lethal fetal anomaly, and the women aged 18 or more years of age and were able to give a written consent. The exclusion criteria were that if a decision had already been made for the delivery within the next 48 hours, the participant was excluded. Any known allergy to any component of the ursodeoxycholic acid or placebo tablets, a triplet or a higher order multiple pregnancy. Randomization and masking. The participants were randomly allocated to receive ursodeoxycholic acid or placebo. Randomization was done using a probabilistic minimalization algorithm to ensure an approximate balance within the following groups: the study center, the gestational age at randomization, the singleton versus twin pregnancy, highest serum bile acid concentration before randomization. The minimization algorithm was implemented by a MedSciNet database programmer with a balance and predictability checked by an independent national perinatal epidemiology unit, clinical trial unit, statistician during the trial. Randomization was managed via a secure web-based randomization program. Randomization and masking. The two types of tablets appeared identical in size, shape, and color. The packs of ursodeoxycholic acid or placebo in identical packaging were produced by a central manufacturing unit at Guy's and St. Thomas Hospital in London and was shipped to the site pharmacies. The tablets were packaged for oral administration and did not require any specific storage conditions. The women who were taking ursodeoxycholic acid at enrollment agreed to stop the medication at randomization. Trial participants, clinical care providers, outcome assessors, and data analysts were all masked to allocation. Procedure. Each film-coated ursodeoxycholic acid tablet contained 500 milligrams of ursodeoxycholic acid, which was the active ingredient, and inactive ingredients were magnesium stearate, polysorbate 80, povidone K25, microcrystalline cellulose, colloidal anhydrous silica, prospovidin, and talc. The placebo tablet contained identical inactive ingredients. The women were started on a dose of 2 oral tablets per day in the ursodeoxycholic group. The dose was increased by a healthcare professional in increments of 1 tablet per day every 3 to 14 days if there were no biochemical or symptomatic improvement, to a maximum of 4 tablets per day, which was equivalent to 2000 milligrams of ursodeoxycholic acid per day. The treatment regime was based on the clinician's discretion. The dose could be reduced to 1 tablet per day, which was equivalent to 500 milligrams of ursodeoxycholic acid per day at a clinician's discretion. For example, if a woman's body weight was less than 50 kgs or if gastrointestinal side effects occurred, the tablet was reduced. The study recommended that treatment should be continued from enrollment till the infant's birth. Clinical teams reviewed the participants at routine care clinic visits until delivery. Antenatal care, particularly the timing and mode of delivery, was at the discretion of the responsible clinician. Outcomes were recorded on the web-based trial database through case note review by trained researchers after discharge of the woman and infant. The primary outcomes which were assessed were perinatal death, that is in utero fetal death after randomization, or known neonatal death up to 7 days after birth. Preterm delivery, that is less than 37 weeks of gestation. Neonatal unit admission for at least 4 hours, that is from birth till the hospital discharge. The secondary outcomes which were measured antenatally were maternal serum concentrations of bile acids, alanine transaminase or aspartate transaminase, total bilirubin, gamma glutamyl transferase, maternal itch score. This was measured as the worst episode of itch over the past 24 hours in mm on a 100 mm visual analog scale. The secondary outcomes which were measured after maternal discharge were gestational diabetes mellitus, mode of onset of labor, estimated blood loss after delivery, and the secondary outcomes which were measured after infant discharge were components of the primary outcome, mode of delivery, birth weight and birth weight percentile, gestational age at delivery, presence of meconium, IPGAR score at 5 minutes, umbilical artery pH at birth, and the number of nights in the neonatal unit. The sample size was informed by the Cochrane meta-analysis. Statistical analysis was done at Stata version 15. Unmasked data were made available for analysis only after a full database lock, after all the data entry had been completed and queries resolved, or on request by the data monitoring committee. All analysis followed the intention to treat principle. That is, all randomly allocated women and infants were analyzed according to the group they were allocated to, irrespective of the treatment they received, if any, or irrespective of any crossover which was done. Coming to the results, a total of 2,737 women were assessed for eligibility, out of which only 1,418 were considered eligible. The rest of the 813 declined to participate, out of which 108 did not want to be randomly allocated, 112 they did not want ursodeoxycholic acid, 287 did not want ursodeoxycholic acid but were not interested in research. And for others, the reasons were missing. From the 605 women which were randomly allocated, the 305 were allocated to ursodeoxycholic acid group, out of which 300 received ursodeoxycholic acid and 5 received no treatment. 24 discontinued intervention, 10 according to clinician's decision and 16 according to participant decision. 304 women were analyzed for primary outcome, and from those women, 322 infants were analyzed for primary outcome from the ursodeoxycholic acid group. From the placebo group, 300 women were allocated to placebo, out of which 296 received placebo and 4 did not receive treatment. 1 woman withdrew from the trial and 1 withdrew the consent for further data collection. In the placebo group, 300 women were analyzed for primary outcome and 318 infants were analyzed for the primary outcome. This table shows the baseline maternal characteristics for both the groups which were allocated in the trial, and the table shows that the baseline maternal characteristics in both the groups were almost similar. Coming to the gestational age, the women who were belonging to less than 34 weeks of gestational age were 133, that is 44% in both the groups of ursodeoxycholic acid as well as placebo group. The itch score, the medications which were received for pruritus in both the groups were comparable for ursodeoxycholic acid group as well as for the placebo group. Antihistaminics were given to 41% of ursodeoxycholic acid group and 40% in the placebo group. Topical emollients were given in 34% of the ursodeoxycholic group and 34% in the placebo group. In the ursodeoxycholic acid tablets were given 5% in the ursodeoxycholic group and 4% in the placebo group. The highest baseline serum concentration of bile acids before randomization, the bile acids were less than 40 in 76% of the cases in both the groups, and for more than 40%, more than 40 micromoles per deciliter of serum bile acids were in 24% of women in both the groups. Similar were comparable in other enzymes, that is alanine transaminase, aspartate transaminase, gamma glutamyl transferase, and total bilirubin. This table shows the perinatal outcomes in both the groups. There was no significant difference which was found in the median gestational age at delivery. The proportions of infants who were delivered by spontaneous vaginal birth or cesarean section were similar in both the groups. And the incidence of primary outcomes, that is perinatal death, preterm delivery, or neonatal unit admission for more than equal to 4 hours did not differ significantly between the two groups. There were 74% of the infants who died perinatally in 74% of the ursodeoxycolate group and in 85% of the placebo group, out of which in utero fetal death were in less than 1% case in ursodeoxycolate as well as placebo group, and 17% of the infants delivered prematurely in ursodeoxycolate group. The neonatal unit admission for more than 4 hours were comparable in both the groups, that is 14% in ursodeoxycolate group and 17% in the placebo group. The mean gestational age at delivery was comparable in both the groups, that is 37 weeks plus minus 5 days. The mode of delivery, in ursodeoxycolate group, 60% of the women delivered by spontaneous vaginal birth and were having cephalic presentation. The breech vaginal extraction was in 1%, less than 1% in ursodeoxycholic acid group and 1% in the placebo group. The cesarean section was done in 11% in both the groups of ursodeoxycholic acid as well as placebo group. Coming to the maternal outcomes in both the groups, post-randomization, the maternal itch score was lower in the ursodeoxycholic acid group than in the placebo group. The itch score was in 241 women. The itch score was around 49.5, that is 12.9 mean in ursodeoxycholic acid group and 13.3 in placebo group. The difference was, the p-value was 0.005, which was statistically significant. The gestational diabetes mellitus, this was seen in 1% cases of ursodeoxycholic group and 3% cases of placebo group. This difference was not statistically significant. The maximum dose of trial medication, that is the ursodeoxycholic acid tablet, which was given, one tablet once a day was given in 1% cases of ursodeoxycholic group. One tablet twice a day was given in 67% of the patients. One tablet three times a day was given in 20% of the patients, and 2 tablets twice a day, that is the maximum dose, was given in 12% of the cases. For the mode of onset of labor, 11% of the patients had spontaneous onset of labor in ursodeoxycholic acid group, and 18% of the patients had spontaneous onset of labor in placebo group. 71% of the cases were induced for preterm rupture of membranes and was induced electively in ursodeoxycholic group, and 67% of the cases in placebo was induced for the pre-labor rupture of membranes and for elective induction. In 18% of the cases of ursodeoxycholic acid group, the pre-labor cesarean was done, and 15% of the women underwent cesarean in placebo group. The estimated blood loss at delivery, it was comparable in both the groups, that is less than 500 ml of blood loss in 64% of the ursodeoxycholic acid group and 62% of the placebo group. And only around 10% of cases in both the groups had blood loss of more than 1 liter. This table shows the trajectories, which was according to the actual trajectory in both the groups and the estimated mean trajectories in both the groups. The first comparison is between the ICOG score. According to the actual trajectory, it was seen that after initiation of the ursodeoxycholic acid treatment, there was a significant decline in the maternal ICOG score, but as the weeks of gestation progressed, that is around the third trimester of pregnancy, there was no significant difference between the ICOG score, and it was seen to be raised. Whereas, according to the estimated trajectory, the ICOG score was estimated to remain stable throughout the treatment after the initiation of the treatment. The second line diagram represents the bile acid concentration, that is actual trajectory after initiation of the treatment. There was no significant change which was found in the bile acid concentration. The bile acid concentration was seen to be initially decreasing after the starting of the therapy, but along the increase in gestational age, the bile acid seemed to be raised. Whereas the estimated trajectory in the serum bile acid concentration was estimated to remain stable throughout the treatment, but along the third trimester, maybe because of the other causes which causes the increase in bile acid concentration, the bile acid concentration was estimated to be increased in the third trimester. Similar results were found for the alanine transaminase concentrations with the start of the ursodeoxycholic acid treatment. The alanine transaminase value was found to be decreasing along the increase in the period of gestation. Coming to the serious effects or adverse effects which was seen with the trial, 8 of the serious adverse effects were reported, out of which 6 were in the placebo group, and none of the serious adverse effects was considered to be related to the trial intervention. According to the classification of the serious adverse effects, the system which were affected were congenital, familial, and genetic disorders in only one case of placebo group, hepatobiliary disorders, infections and infestations, metabolism and nutrition disorders, pregnancy, prepurium and perinatal conditions, and reproductive system and breast disorders in 6 of the placebo cases. The adverse effects which were not related to study intervention were 15 in the ursodeoxycholic acid group and 31 in the placebo group, which were possibly related to the study intervention were 8 in the placebo group and 8 in the ursodeoxycholic acid group and 9 in the placebo group, and which were probably related to the study intervention were only 1 in the ursodeoxycholic acid group. And the system organs which were affected by the adverse effects were blood and lymphatic system disorders in 4 of the patients in both the groups, for just gastrointestinal disorders in 10 of the patients for both the groups, and pregnancy, prepurium and perinatal conditions in 7 of ursodeoxycholic acid group and 18 of placebo group. According to the adverse effects which were seen and the clinicians' discretions, the participants were told to discontinue intervention. 8% of the participants were told to discontinue intervention in ursodeoxycholic acid group and 10 in placebo group. Coming to the discussion, this is the subgroup analysis which shows this, first or the perinatal or primary outcomes of the study comparable to the other studies which were done. In the study, population had a similar range of elevated serum bile acid concentrations to other multi-center cohorts, which were around 3/4 of the women with bile acid concentration were in the range of lower than 40 micromoles per liter. According to the other studies which were also conducted related to ursodeoxycholic acid group, the most of the women which were enrolled in the study had the serum bile acid concentration of lower than 40 micromoles per liter. The mean estimated range affecting the preterm delivery in both the groups of ursodeoxycholic acid of the serum bile acid randomization of less than 40 micromole per deciliter and more than 40 micromole per deciliter were comparable in all the studies, but this was the results were not found to be statistically significant since the p-value was 0.5. In the subgroups of women which were identified by higher peak bile acid concentration at study enrollment, there was no discriminable effect of ursodeoxycholic acid on the primary perinatal outcomes. In this trial of women with intrahepatic cholestasis of pregnancy, the ursodeoxycholic acid has not been found effective in reducing a composite of adverse perinatal outcomes. Although the ursodeoxycholic acid appeared to be safe, this has no clinically meaningful effect on maternal itch symptoms. This did not reduce the maternal bile acid concentrations, and the reduction in alanine transaminase was also of uncertain clinical significance because the alanine transaminase is not known to be associated with the risk of stillbirth or preterm labor in intrahepatic cholestasis of pregnancy, and the alanine transaminase value is non-specific. A 2019 meta-analysis identified that the risk of stillbirth increases in women with intrahepatic cholestasis of pregnancy with a peak bile acid concentration of at least 100 micromole per liter, and that the risk of preterm birth increases with peak bile acid concentration of at least 40 micromoles per liter. According to the RCOG guidelines, the 40 micromole per liter of serum bile acid concentration has been considered as moderate intrahepatic cholestasis of pregnancy. Although some secondary outcomes appear to be significantly different at 95% of the confidence intervals, the effects do not support a unified action related to ursodeoxycholic acid. The strength of the study was its size, which was considerably larger than any previous trial which was identified in the literature. Recruitment reached the target number of participants within the pre-specified time period, which indicated that there was a willingness of the participants from clinicians and the pregnant women. Coming to limitations of the study, the limitation of the study was that the incidence of primary outcome in the control group was lower than that which was estimated for the sample size calculation. Trial primary outcome event rate was reviewed by the data monitoring committee, but because the event rate was similar in both the two groups, in extending the trial was not considered to be necessary. Conclusion. The other trials in the intrahepatic cholestasis of pregnancy have reported a similar reduction in bile acid or alanine transaminase concentrations in the placebo group. These results highlight that the placebo groups might provide the most unbiased assessment of the natural history of a condition. The pooled results do not show a significant difference in most adverse perinatal outcomes between the treatment with ursodeoxycholic acid as well as with the placebo. The ursodeoxycholic acid is but considered only treatment consistently proposed in the guidelines as a disease-modifying drug because no other treatments are widely used for prevention of the adverse perinatal outcomes, which was associated with the intrahepatic cholestasis of pregnancy. In women with peak bile acid concentrations lower than 100 micromole per liter, the risk of stillbirth is similar to that of the general pregnant population, whereas the risk is significantly higher in women with peak bile acid concentration of at least 100 micromole per deciliter at any time in pregnancy. The only intervention to affect adverse perinatal outcome is likely to be appropriately planned delivery. Thank you.
Wonderfully presented, Neetika.
Yeah.
So very, very, very clear. May I now request Dr. Anjana Khanna ma'am to give her inputs.
Yeah, that was very well done, and it was very well put forward. And though I believe that the itch score was sort of marginally, you can say that it was a bit reduced. And since it intrahepatic cholestasis of pregnancy, we are at a loss what to do, what to give, how to help the patient, because the patient is so distressed at the time, at some time she even wants to terminate her pregnancy. So in that case, at least there is a marginal reduction, and we don't have much choice in this situation. So though the results were not statistically much significant, but I think in the itch score and in the alamin transaminases group, there was a slight reduction. So maybe we can take that as a pointer that, well, it could help some women at least, if not all.
Yes. Ma'am.
Yes.
Reena? Reena, are you there? Reena Vani?
Hello. Yeah.
Yeah, yes, Reena, please.
This is actually a very important clinical topic, and it's been well presented by the team. But sometimes, even if and what I appreciated about this study was the wonderful way they have randomized the two groups of patients, the placebo and the thing. So, and they have, what I also appreciated how the presenter talked about the funding. When we are looking at a study, you have to look at conflict of interest. Do you feel it's biased or somebody? So when the way we look at the studies, however, having said that, even then, we are looking at the fact that in certain situations, as Dr. Anjana also mentioned, we may be using this drug. It is better than nothing. And if there is symptomatic relief of the patient, to be honest, I definitely do use this particular drug, and we use it in given situations, along with other interventions like high carbohydrate diet, treating correcting factors, and of course, the final way is delivery. So I congratulate the entire team for a very good selection of a clinically appropriate paper. And I'd like to just end with one more word. We are using progesterones left, right, and center. That also I'm finding, along with that, and with, of course, high-risk factors in pregnancy, we are getting a slightly increased incidence of these symptoms of pruritus and changes in the bile salts and bile acids. So I think these are things we have to keep in mind.
And another thing is that sometimes giving vitamin D in cases of vitamin D deficiency patients, it also helps.
Yes,
in
so
these
correction
cases.
of vitamin D deficiency, simple things like good nutrition, balanced diet is the way to help our pregnant patients.
Yeah, and then I always tell them to cut down on their fat intake, because somehow that helps the liver in some way or the other.
No, and madam, as it is said, a low protein, and otherwise everybody is now into protein, and the paleo and the keto diets, which we don't advise in pregnancy. But in liver disorders, what we have to remember is a high carbohydrate diet protects the liver, avoids the hypoglycemic things and the fluctuations, and that is what actually leads to stillbirth. The unexplained or undiagnosed hypoglycemia is what has led to the stillbirth. So that's the way forward. Thank you very much.
Yeah.
Can I request Dr. Kannagi madam to comment on the paper? But it's an obstetric paper, but your comments, because there was a line on progesterone somewhere. So as an
Yeah.
infertility specialist, what is your thought on it? Ma'am, you have to unmute yourself, ma'am. Kannagi, ma'am.
Yeah,
Yeah.
we do give a lot of progesterone, both in fertility management, abnormal uterine HMB also we give. And so far, we don't come across so much of a liver issue. We come across more of thrombosis and, thrombotic events rather than cholestasis or any other dairy function. So I think, yeah, marginal benefit of relief of symptoms, it may vary from patient to patient. So it will not reflect in a big study like this. So, but then when we have nothing else to give and relieve her pruritus, we might as well try this when it is not going to cause harm. That's what I would say.
Thank you.
Yeah,
ma'am.
but it is said that the progesterone we keep on giving, as Reena said, left, right, and center. And it is this progesterone, the metabolism, the metabolites of this progesterone also can lead to some extent to intrahepatic cholestasis.
Ma'am, we'll need to have a trial on that to say categorically that progesterones are the ones which is causing the increase in itching somewhere. And actually, I wanted to ask Neetika, like, what is the time of the study? How did you get so many cases of intrahepatic cholestasis of pregnancy when we hardly see, like, probably once in a year or something like that? Neetika, what was the period of study?
Yes, ma'am. It was done for 8 long years, and
8
the
years.
women. Yes, ma'am.
How many centers? 33 centers, I think.
33 centers.
33
in
centers.
India.
Yeah, that
Yes.
was a big study. Then you have to wait for the patient to come. And it's so difficult to randomize when you have such the cases are not easily available and you wait for them. I think it was one of the best studies to have been done on this drug. And you said they took the diagnostic feature as 40 for bile acids, or 10 it was?
Ma'am, in the study, there are only 2 groups which are mentioned, the
Okay.
serum bile acid concentration of less than 40 and more than 40.
Okay.
And but according to the diagnostic criteria mentioned in RCOG, it is in 19 micromole per deciliter, which is
So,
the cutoff range.
Cutoff range. So here they took 40, right?
Yes,
And
ma'am.
you mentioned something about moderate level and high level or something like that for 40.
Ma'am,
Where did you get that?
And this
No,
is
that
not
was moderate intrahepatic cholestasis was at 40.
Madam, that's what I'm saying. What level they took it as moderate, I'm asking.
40,
ma'am,
she said.
this was not according to this study, but because but according to the RCOG guidelines, which is mild intrahepatic cholestasis from 19 to 40, moderate from 40 to 99, and severe more than 99.
90.
Okay.
And the preterm delivery, I'm not talking about the drug now, but in this group of placebo as well as the drug, there was a higher risk of preterm delivery, right?
Yes, ma'am.
And iatrogenic it was, or it was spontaneous?
Ma'am, mostly it was iatrogenic preterm deliveries. They have mentioned that in most of the women, the pregnancy was terminated at around 37 weeks of gestation.
And why did they do that? What was the main reason? Any they done an analysis of that?
Ma'am, they have not mentioned as such the reason of the termination of pregnancy at 37 weeks, but they have said that there was a fetal demise at 35 weeks of gestation.
Yeah, the one in the drug group and 2 in the placebo group, there was a stillbirth. That's what I saw in that analysis you had put up, right?
Yes,
1 and 2. And but why did they terminate so many patients, I'm asking, when it was a itching or symptomatic, or what was the reason which made them terminate? Because we tend to, like, suppose a drug is not useful and her itching has become worse, we need a cutoff to deliver her. So what was the cutoff they took?
Ma'am, in the study or discussion, they have not mentioned any reason to terminate the pregnancy at 37 weeks of gestation.
Kavita, what are your thoughts on that? What could have made them
I was just
deliver
wondering,
so
there
many
could be
babies?
some other confounding factors like hypertension or GDM, etc., because fetal growth restriction. Because as such, I don't think they have considered all this in the study.
study, because that would have helped us like how to manage an intrahepatic cholestasis also, no? Like what is the, how long will you continue with this pregnancy? What will make you take a stand to deliver her earlier?
Yes.
That would have helped much
So
better.
I think they have put that on the clinician. The decision is on the clinician. Because it's at appropriate timing. And plus, I think if the bile acids are more than 100, then you have to be really alert regarding poor perinatal outcome. But I think it is the study is indicating more towards symptomatic relief with ursodeoxycholic acid. And in our practice, I think every day we are seeing these patients and they do improve with this. That is my
the drug is according to the study, the drug was not useful for the perinatal outcome. It has made it very clear, but the itch score reduced, and I think it was significant also. That's what she
even the biochemical parameters they may reduce, but not as much.
So we actually the monitoring the mother and baby should be like much better. You cannot rely on the drug to help you in any way. And they took a call at 37 weeks because we are scared of stillbirth and the levels were rising. I think that was one reason. And Reena was already talking on carbohydrate diet, and we're talking on GDM also. So are we introducing GDM just to correct the liver also there? That is also a thought. Thank you. Thank you so much, Ritika. That was wonderfully done. Parag, would you like to say something?
Very interesting paper as well as discussion. Sometimes I wonder how wonderfully these youngsters make presentations. Right, and it's really nice to have so many seniors who are giving feedbacks. So all in all, it's going on well. I'm sure the delegates are also happy too.
Thank you, Parag. Saswati madam, would you like to say something? She's an obstetrician from the Northeast. Her inputs.
So,
unmute
please unmute Saswati ma'am. Please take support.
Saswati, you can unmute yourself now.
Unmute yourself.
Yes.
Okay,
yes.
okay, yeah, now it is working. I was trying to. It's a very nice study. And in fact, when I was pregnant, I had, in my first pregnancy, I had the teaching problem. At that time, ursodeoxycholic acid was not in the field. And my madam, she never thought of terminating it before 37 weeks. Only 2 days prior to my expected preterm, I was delivered. But thankfully, there was no issues. So probably this, whatever the change is, and in fact, if you ask me, I don't consider this problem that it is going to have much more problem in the fetus. I know the incidence of meconium stain lichens is little higher, possibly, but I won't go beyond the date. But delivering them at 37 weeks, I am not very much into that. I don't think it is that necessary. Moreover, if you give a liver function profile for all patients, the bile acid doesn't come unless you give it separately. You have to give the bile acid. That is another issue. We like LFT is written.
Yes.
So it is everywhere that opportunity is not there. And regarding that, Reena has brought out a very nice issue, that progesterone. I have done a study with different types of progesterone and the effects on the liver enzymes. And I have seen when a patient gets both forms of progesterone, injectable plus oral, multiple times, some people they give, especially for infertility and some patients who are having capacitive abortion. In them, we have seen that the liver enzymes, the possibility of increasing liver enzymes is higher. I think this needs much more study, because so many progesterone use money empirically, which is not indicated. So we should think of doing that particularly. So very nice. I thank you so much for giving me the opportunity for speaking in this forum.
Thank you, ma'am. So it
Thank
is
you,
actually
Saswati.
thank you.
Yeah.
It is actually much ado about nothing then. We are talking too much of intrahepatic cholestasis when it doesn't even cause problems in many of them.
I think we should try to correlate events, the pruritus, the cholestasis, and any decline in the liver function. If we can get a pathway that this leads to this, or this is the next event, and I think that would be give us directions whether to take this cholestasis seriously or not. I think find the link.
And many labs are not doing bile acids actually.
We're not doing bile acids.
You have to specifically poke them into doing.
I think we have to move on to the next article, ma'am, because you got on an hour left. May I request the next presenter to present the article? Kavita, please introduce it.
So our next presenter is another postgraduate, second year. She is Dr. Sakshi Sharma, and she'll be presenting on septum resection versus expectant management in women with a septate uterus. This is again an international multicentric open label randomized controlled trial. And this was published in 2021 in Human Reproduction. So another very important topic, because we come across septal uterine septum in some of our unexplained infertility as well as in reproductive pregnancy losses. So let's go on, and I'll ask Dr. Sakshi to please share a screen and present. Dr. Sakshi Sharma. Please unmute yourself, Dr. Sakshi.
Unmute कहाँ से करना है?
The first slide and slideshow. From the beginning, yeah.
So good evening, everybody. Myself, Dr. Sakshi Sharma. I'm second year resident at Christian Medical College, Ludhiana. And the topic of my journal is septum resection versus expectant management in women with septate uterus. It is an international multi-center open label randomized controlled trial. So septate uterus, it is a congenital uterine anomaly with a prevalence of around 2.3 to 0.2% in women of reproductive age group. It is associated with increased risk of subfertility, pregnancy loss, and preterm birth. As per American Society of Human Medicine guideline for management of septate uterus, they recommend against the hysteroscopic resection. But in contrast, the guidelines on recurrent pregnancy losses associated with septate uterus from ESHRE, NICE, and RCOG do not support the use of the procedure until adequate data available for the effectiveness. Recently, a large cohort study including 257 women with a septate uterus showed that surgery did not improve chances of conception, nor did it appear to prevent pregnancy loss or preterm birth. Thus, to prove a high level of evidence, they have performed a randomized controlled trial comparing hysteroscopic septum resection with expectant management in women with a septate uterus. My journal was taken from the Journal of Human Reproduction, volume 36, issue 5 of the year 2021, and published by the Oxford University Press on the behalf of European Society of Human Reproduction and Embryology. The TUS trial, that is the randomized uterine septum trial, was registered within the Netherlands trial register. The trial protocol and all subsequent amendments were approved by the Medical Ethical Committee of the Academic Medical Amsterdam, the Netherlands, on 28 October 2008, and by the Board of Directors of all participating hospitals. All adverse and serious adverse events suspected of having a causal relationship to study was recorded, and all serious adverse events were reported to the Ethics Committee of the Academic Medical Center, Amsterdam. So first we'll discuss material and the methods. It is an international multi-center open label randomized controlled trial carried out in centers with expertise in hysteroscopic septal resection. These centers were 3 tertiary care centers in USA, UK, and Iran, and 4 secondary care hospitals collaborating in the Dutch Consortium for Women Health Research. The study was conducted between October 2010 and September 2018. Women with reproductive age with septate uterus and wanted to conceive and having a history of subfertility, pregnancy loss, and preterm birth were included in the study, and women with any contraindication to the surgery were excluded. Initially, after ethical study approval, only women with recurrent pregnancy loss were included, but during the course of the trial, the eligibility criteria were extended to include women with a history of subfertility, pregnancy loss, and preterm birth. So these are some of the important definition we need to know before knowing about the study. This includes subfertility, that is the inability to conceive for a minimum period of 12 months of trying to conceive. Then pregnancy loss, it is defined as the spontaneous demise of the pregnancy before 24 weeks of gestation, including non-visualized or biochemical pregnancy confirmed by either serum or urine beta HCG. Then recurrent pregnancy loss, which is 2 or more, not necessarily consecutive pregnancy losses. Then the clinical pregnancy, it is the absence of fetal heartbeat or at beyond 6 weeks of gestation. Ongoing pregnancy, it is a viable intrauterine pregnancy of at least 12 weeks duration confirmed by an ultrasound scan. Preterm birth, it is the birth before gestational age of 37 complete weeks. So the diagnostic criteria which was followed to diagnose the septate uterus is as follows. A septate uterus was diagnosed by the treating consultant according to the leading classification system at the time of recruitment. The presence of a uterine septum was ascertained by hysterosalpingography, three-dimensional pelvic ultrasound, MRI, saline or gel infusion sonohysterography, or hysteroscopy combined with laparoscopy. So randomization and blinding. Women were randomly allocated in 1:1 ratio to hysteroscopic septum resection or expectant management group by using a central password protected internet-based randomization program. The randomization list behind the program was prepared by an independent statistician with a variable block size with randomly selected block sizes that varied between 2, 4, and 6. Neither the recruiter nor the trial project group could assess the randomization sequence, but because of the nature of the intervention, blinding women or the doctor was impossible. So first of all, in septum resection group, women allocated to this group got their surgical procedure performed under general or local anesthesia. The choice of the instrument was left to participating surgeon, which include monopolar or bipolar resectoscope with needle or loop electrosurgical electrode, bipolar electrode, that is Versa point, or conventional mechanical seizure. Then to monitor the depth of myometrial resection and to prevent uterine perforation during surgery, laparoscopic and ultrasound monitoring was advised. To assess the result of septum dissection, a diagnostic control hysteroscopy was done 6 to 8 weeks post-operatively. Whereas in expectant management group, women did not receive any specific intervention and were advised to continue trying to conceive naturally or with artificial reproductive technology in case of sub-infertility. In women with recurrent pregnancy loss or coexisting APLA syndrome, low dose aspirin or low molecular weight heparin were allowed. Women could opt for septum dissection if first pregnancy after randomization resulted in pregnancy loss or if pregnancy did not occur even within 1 year of follow-up. So the sample size. For the sample size calculation, estimated live birth rate was taken to be 35% in women with septate uterus without surgery and were expected to increase to 70% with surgery based upon a retrospective study conducted by Homer et al. In the year 2000 and Chan et al. In the year 2011. Using a two-sided test, an alpha error of 5% and a beta error of 20%, 62 women were needed to demonstrate this difference. Anticipating loss to follow-up and protocol violation, an additional 10% was needed. Thus, a minimum of 68 women were planned to be randomized. The study aims to primary outcome with the conception leading to live birth within 12 months after randomization, which is defined as the birth of a live fetus beyond 24 weeks of gestation. Secondary outcome include clinical pregnancy, pregnancy loss, ongoing pregnancy, and preterm birth with conception leading to these outcomes within 12 months after randomization. In women with ongoing pregnancy, pregnancy outcomes such as multiple pregnancy, ectopic pregnancy, placental abruption, uterine rupture, and mode of delivery were assessed. The data were then analyzed on intention to treat basis relative risk and 95% confidence limit for all pregnancy outcomes were calculated. To account for time to conception leading to live birth, Kaplan-Meier curves were constructed using log rank test to compare the treatment arm and calculating the corresponding hazard rate with 95% confidence limit. Additionally, per protocol analysis were done to women who were treated according to their allocated study arm. SPSS VR software were used for all statistical analysis with a version 25. Between 20th October 2010 to 3rd September 2018, 80 women were ultimately randomized and allocated to septum resection and expectant management group as 40 and 40. So among the women who were 40 women who were allocated in septum resection group, only 39 were analyzed by intention to treat as one withdrew the consent immediately after the randomization. Out of those 39 women who were analyzed by intention to treat, only 36 were analyzed per protocol because during the course of the study, 2 had an expectant management because when they were taken up for surgery, there were no septum identified and 1 lost to follow-up. Whereas 40 women who were allocated to expectant management group, 40 were analyzed by intention to treat, but over the course of the study, 5 have septum resection, out of which 1 woman had a septum resection after 1 month, 3 after 4 months, and 1 woman after 9 months of follow-up, and 2 women lost to follow-up. As a result, ultimately only 33 were analyzed per protocol. So these are some of the basic characteristics which were compared between the septum resection and expectant management group. These are age, parity, BMI, smoking status, inclusion criteria, including pregnancy loss, subfertility, and preterm birth. Then diagnostic criteria, whether the woman is having partial septum or complete septum, and the diagnostic procedure used, which includes saline infusion, sonography, 3D ultrasound, MRI, HST, hysteroscopy plus laparoscopy. Baseline characteristics were found to be similar between the 2 groups. Then these were the various modalities used for the surgical group. As far as the most common energy modality used for the septum resection were the resectoscope, which account for 64% of the women, that is 25 out of 39 women. The most common imaging modality is the laparoscopy, that account for 72% of the women. Out of the 39 women who underwent septum resection, 36 women, that is 92%, have a successful complete resection. Only 1 woman and 1 uterine perforation occurred immediately after the introduction of hysteroscope. As a result, after which the surgeon stopped the procedure immediately and the septum was removed 4 weeks later without any further complication. And the repeat procedure, that is incomplete septum resection, were found in 5% of the women, that is 2 out of 39. So these are the reproductive outcomes in per protocol analysis and intention to treat basis. So the mean time to conception is 9.2 months after following randomization of septum resection and 9.2 months after randomization for expectant management group with a hazard ratio of 0.83%. In the intention to treat analysis, 12 out of 39 women who were allocated to septum resection, that is 31%, has a live birth compared to 14 out of 40 women who were allocated to expectant management group, that is 35%. This corresponds to relative risk of 0.88% with a 95% confidence limit lying between 0.47 to 1.7. and an absolute risk difference of minus 4.2%. There was also no evidence of a difference in clinical pregnancy, ongoing pregnancy, pregnancy loss, or preterm birth in both the groups. So these are the pregnancy outcome for women with an ongoing pregnancy. The most common presentation which is found in septum resection group is cephalic presentation that account for 85%, that is 11 out of 13. And the most common mode of delivery is cesarean delivery. In the septum resection group, the reason for cesarean section delivery is found out to be 3 in elective women: non-progression of labor 1, fetal distress 1, and placenta previa 1. And 4 women had cesarean section for some unknown reason. And the reason in women who were allocated to expectant management, 3 women have LSCS due to breech presentation, and 2 underwent cesarean section due to fetal distress. So this is the Kaplan-Meier analysis curve for the women who underwent septum resection and women who have expectant management. The log rank p-value is 0.64% with a corresponding hazard ratio of 0.83, with 95% confidence limit lying between 0.39 to 1.9. So the strength of the study. It was a pragmatic study in which women have been diagnosed by their treating gynecologists in 10 centers in 4 countries worldwide, based upon the leading classification at that time. This reflects daily practices and ensure a high regenerability of the study result. There was high compliance, that is, only a few women were lost to follow up over the course of the study. Limitation: the sample size was limited and the recruitment took a long period, that is 10 years. Since surgical techniques did not fundamentally change over time, thus the latter is considered of limiting clinical significance. Discussion: as per the study, septum resection did not improve live birth rate compared with expectant management. There was also no evidence of difference in other reproductive outcomes like ongoing pregnancy, pregnancy loss, and preterm birth. One complication of the treatment, that is perforation, was sustained during the septum resection. The study was able to detect an improvement in live birth from 35% to 70% with surgery, which was expected based upon the existing literature at the time of study conducted by Homer et al. In the year 2000. To detect a small improvement of 10% in live birth, for example, from 35% to 45%, new study would need to recruit at least 752 women. Study findings are in line with the recently published international cohort study of 257 women with a septate uterus, which showed no difference in live birth rate between women who underwent septum resection and women following expectant management. This study was not powered to evaluate any differential effect of septum resection in women with pregnancy loss compared with those presenting with subfertility or according to the number of pregnancy losses, not the possible differential effect of the size of uterine septum. Complete septa are less common than incomplete septa. That accounts for only 10% of the trial population. Out of 7 women with complete septa, 3 underwent septum resection and 4 had expectant management. The women who underwent septum resection has a birth rate of 66.7% and women who had expectant management has a birth percentage of 75%. Thus, in light of the lack of any evidence for effectiveness and potential for harm, study recommend against septum resection as a routine procedure in clinical practice. Women with a septate uterus need to be informed about the data of the study after counseling according to the principles of shared decision making, and informed decision can then be made. Conclusion: the septum resection did not improve live birth rate compared with the expectant management. There was also no evidence of difference in other reproductive outcome like ongoing pregnancy, pregnancy loss, and preterm births. Thank you.
Another well written and I think well presented, Dr. Sakshi. Excellent it was. Thank you so much. Can you stop sharing? I see Dr. Kaparna who has joined. Before that, can I ask Dr. Kannagi ma'am to give her comments because she's a reproductive medicine specialist.
Okay, well, if you look at the study population, I mean, it's all together, subfertility, pregnancy losses, preterm baby. So, I mean, it would be better if we had 3 arms. One subfertility alone, those with pregnancy losses or those with then the analysis is probably more, it will relate to the what outcome we are expecting. Because there are two different processes, no? In infertility, it's the implantation which we are looking at, and because of the septum, it may be impaired. Whereas in the preterm labor or what, there may be other causes also, apart from the septum, we cannot really know. So I feel it should have had 3 arms.
Do you agree that septal resection should not be done for just infertility?
Yeah, see, it's a very tricky question. And suppose there is a young girl just married 2 years, coming for infertility, you discover the septum, everything else is okay. They've not really tried properly. I wouldn't jump at cutting that septum. But at the same time, there is an older lady, say 32, 33, you're doing a laparoscopy, she's had a long period of infertility. Yes, what's wrong in cutting the septum? It's not going to cause her. Along with the laparoscopy, and you're going to do a diagnostic, there's nothing wrong in cutting that septum.
Yeah. Dr. Aparna,
both sides of the Atlantic, the opinion is different, as usual.
Dr. Aparna, welcome to the program. Thank you so much for joining us at such an early time. May I request for your inputs, please? Unmute.
Definitely. I think here, as you know, the ASRM, the guidelines are a little different. And in the United States, it used to be that we were resecting the septums at one point in time more commonly than others. But I think the data here, this is a randomized control trial. They did randomize pretty nicely, and it's there. But I agree with Dr. Kanaki. Sometimes every study that we look at doesn't need to completely be taken immediately into any clinical, clinical guidelines, but you always have to keep in mind that individual versus like an overall picture, overall, maybe there's no difference in the outcome, but whenever you're interpreting it to one particular person, you probably have to keep in mind like really detailed clinical history, like all the things. It's all about intention not to harm, right? Like, I think if there is a risk of surgery causing other problems, you really have to think 2 times before like subjecting someone to a surgery. We got a perforation, opening, fixing it or something like that may cause way more harm compared to like leaving them alone and trying for it. But the infertility history, I think Dr. Kanaki ma'am put it very nicely together. It probably is still an individual approach. I think even that's why the paper also says, do a shared decision-making, talk to the patients, make them understand the risks and benefits. And then if it is like something that they've tried everything and you have a scope in there, you're kind of preventing yourself from like injuring something, may not be a bad idea, but routinely doing septum resection just by seeing it like as a reflex, you really have to think twice about it. I think these well-studied randomized control trials are there. I think the other thing I also would suggest, like for any journal club, is also to understand like the study design and like to comment a little bit on that. I mean, RCTs, there's not much, but for those who are actually in training, the RCTs, you have something called consort guidelines. I'll put a link in the chat for those who want to look it up. And I think this study was well done and they did follow all the checklists for a consort guidelines. So it's always good to look at the study in that angle too, when we're talking about a journal club. That looked appropriate as well. So I again would say, yes, it's a good study. I think we get something out of it, but when you're translating it to clinically, look at the patient, make sure you do a shared decision-making. No blanket statement applies for any patient. So you always have to keep that in mind.
Thank you so much. Ranjana ma'am, you have to unmute yourself.
Okay. Yeah. Actually, I am also of that opinion, which Dr. Kanaki said, that it should not be as a routine. You just see it and just go about cutting it. Because then addition formation will be there. You can always end up perforation, and there could be a host of other complications of surgery. But besides that, at least give her a fair trial, because so many patients with septum deliver properly, they may have a slightly early preterm delivery. But otherwise, as such, they often encounter no problem at all. So we can't know. Retrospectively, we can say that, yes, this patient was fine and no problem was there. But why should we unnecessarily subject the patient to surgery? That is my stay also. That unnecessarily, unless you are absolutely sure that nothing is working and you are desperate and AMH is low, and now this is, like the only thing left that you can think of, then you can think about resection.
Reena is there? Reena?
No.
Reena is not there. Parag, would you like to say something?
No, I'm sorry. I was in the other fetal medicine meeting of ICOG, so I didn't hear this paper. I welcome Aparna, and we are really thankful to you because it's very early in the morning out there in LA, and thank you for joining. And even at this odd hours, you're still smiling. So we really appreciate
Yeah, it's such a pleasure to see a smile on her face.
He was worried that you will not be able to join, Dr. Aparna. He kept on asking us. We reassured him that you will join.
When you have an iPhone and an alarm, I think anything can happen. And we are obstetricians, so we can wake up at any time and we can put a smile on the face and we can start working.
Dr. Sakshi, there's a question in the chat box. Dr. Nandini has asked, this studies of which country origin? Sakshi?
Ma'am, the study was originally, it was a Netherlands-based study, but they have conducted in UK, USA, and Iran.
Oh, quite different countries. Nandini ma'am, I think that has answered your question. I think we'll go on to the third paper.
Dr. Charmila, can I just add one sentence?
Yes, please.
Because actually this study started initially with RPL, recurrent pregnancy losses, and then went on to include patients of unexplained infertility as well. So like Dr. Kaniki, she was saying that is all including so many patients of different characteristics. Maybe we could include different profile patients in different subgroups and then analyze. So my take would be like in RPL, definitely if a patient is having recurrent pregnancy losses, we would like to resect the septum in those cases. In unexplained infertility, only after ruling out any other, especially in long-standing unexplained infertility, when you rule out other causes. And one more I would like to add, pre-IVF, if you find that before you go in for infertility treatment, which is IVF, and you find on hysteroscopy there's a septum, then I think we would like to resect. Thank you.
Other thing is like 80 cases in that study is not a big thing for India. I think a single center somewhere. Yeah, Kannagi ma'am, I think that is because we see so many patients actually. 80 cases is not a big number.
Yeah, I thought of another thing. We used to see look for septums when we do a breach or a transverse light. So that's again proof that septum is not going to cause, in the past, before we came across this hysteroscopy, days of our training, there were so many septum and they had absolutely normal term, of course, breach or some malposition. That was the only issue there. So are we really looking at the septum causing these problems?
You need to individualize. Don't just rush in and do your septal resection just because you see. If a patient is delivered and you see a septum, please don't touch her. I think that should be the message also. So many do it after delivery also. Yeah. Kavita will go on to the third paper. I think we have 5:30.
So the third paper is again presented by my junior resident. She is in first year, and Dr. Sakshi Goel, and she will be presenting she's presenting on the use of ultrasound sliding sign, something new. So that is a sliding sign on ultrasound for prediction of adhesions in women undergoing a repeat cesarean section. And this was published in the Journal of Obstetrics and Gynaecology in 2023. So a very recent paper. Dr. Sakshi Goel. Sakshi, can you unmute
Yes.
yourself?
Yes.
And slideshow, please.
Good evening, everyone. So the topic of my journal is the use of ultrasound sliding sign for prediction of adhesions in women undergoing repeated cesarean section. This journal has been taken from the Journal of Obstetrics and Gynaecology, volume 43, 2023, and has been conducted in the Department of Obstetrics and Gynaecology, Faculty of Medicine, Asyut University, Egypt, and Eliman Specialized Hospitals of Obstetrics and Gynaecology, Egypt, by Dr. Ali H. Yusuf, Dr. Ala Eldin Yusuf, Ahmad M. Abbas, Ahmad Muhammad, Shima Mustafa, and Mustafa Ibrahim. So cesarean section rate has dramatically increased, as we all know, in the last decade, up to 32% in USA and 38% in Asyut University, Egypt, where the study has been conducted. Cesarean sections are associated with many intra as well as post-op complications. Early complications including hemorrhage, bowel and bladder injuries, sepsis, and post-op ileus. Remote complications including placenta accreta spectrum, intraperitoneal adhesions. The incidence of intraperitoneal adhesions varies from 12 to 75%, depending on the number of previous cesarean sections, type of suture material used, and the level of hemostasis achieved. So a multidisciplinary team must evaluate these patients before surgery. Intraperitoneal adhesions, they increase the difficulties with surgery, causing higher incidence of bowel injury, bladder injury, increasing the health burden leading due to complicated surgery and the consequences. They're also increasing the financial burden due to prolonged surgery and post-operative stay. So ultrasound can be used to detect adhesions in these patients. There have been studies where they have either small sample size or they have used a transvaginal ultrasound for detecting the adhesions. But the transvaginal ultrasound is not available universally. So the study objective is to validate the use of ultrasound sliding sign, which is a transabdominal ultrasound, to predict intraperitoneal adhesions in women undergoing repeated cesarean section. So this is the ultrasound sliding sign. We call it a positive sliding sign if the interior uterine wall is moving freely against the anterior abdominal wall, which indicates no adhesions. And it is a negative sliding sign if the interior uterine wall had a limited mobility against the anterior abdominal wall, which indicates the presence of adhesions. So coming to the materials and methods, this study is a blinded cross-sectional study which has been carried out between February 2019 and February 2020 in the Asyut University Hospital, which is a tertiary care hospital, and Eliman Specialized Hospital of Obstetrics and Gynaecology, Egypt. This study included 120 pregnant women in third trimester who were examined for the sliding sign before their elective cesarean section. Before discussing the further details of the methodology, I would like to study in brief about the cross-sectional study. So the cross-sectional study design, it is a type of an observational study design where the investigator measures the outcome and the exposure in the population and can also study their association. So the participants are recruited based on the inclusion and exclusion criteria. Then we study the exposure and outcome in the patient at the same time, and then we estimate the prevalence of the outcome and exposure, and we can calculate the odds ratio. Strengths of a cross-sectional study are: it is a faster and inexpensive method to study. It can be used before cohort studies, can be used for public health monitoring and planning. But the limitations are that we cannot derive causal relationships from the study, and we can calculate the prevalence and odds ratio based on the study. Just briefly comparing various observational studies like the case control cohort and cross-sectional study. In the case control study, the participants are selected based on the outcome status, and then the exposure is assessed, and we can calculate odds ratio from a case control study. Whereas in a cohort study, participants are selected based on the exposure status, and then the outcome is assessed, and the incidence can be calculated. Cross-sectional studies, participants are selected based on the inclusion and exclusion criteria, and both the outcome and exposure can be assessed, and we can calculate the odds ratio and the prevalence. So the cross-sectional study has to be according to the stroke checklist, which is as follows. The inclusion and exclusion criteria for my study are, inclusion criteria is the women must be aged 18 to 45 years. The women must be in their third trimester with at least one previous cesarean section and who plan to undergo an elective repeat cesarean section and are not in labor. And also women who accepted to participate in the study. The exclusion criteria is women with planned or elective primary cesarean section, women who underwent an unplanned repeated cesarean section because of urgency, women with known connective tissue or collagen diseases, and women with other previous surgery other than cesarean section. So coming to the methodology, eligible women were subjected to preliminary evaluation, including history taking, clinical examination, BMI assessment, and ultrasound examination to ensure the integrity of the pregnancy. Then, all pregnant women who were planned to do an elective cesarean section underwent a preoperative transabdominal ultrasound examination in the supine position by two examiners. Firstly, by a senior resident level 1 sonographer, and then by the specialist who is the level 2 sonographer. The ultrasound was performed using Medicine ultrasound machine 5 MHz abdominal convex probe. The probe was placed perpendicular to just above the site of previous cesarean incision and then moved from above downward and from side to side as we ask the patient to breathe deeply. Then we classify the patients to have positive or negative sliding sign based on the mobility of the interior uterine wall with respect to the interior abdominal wall. Subsequently, another experienced sonographer blinded to the patient data independently classified the patients as positive or negative sliding sign after seeing the video recordings of the ultrasound done. Further, the elective cesarean section was performed by an obstetrician who was blinded to the ultrasound results, and then we asked the obstetrician to report if the adhesions were present or absent. The presence of moderate or severe adhesions was defined as adhesions that cause a very difficult uterine access or the presence of bowel or bladder adhesions to the interior side of the uterus which complicated uterine access. Other findings were classified as no adhesions, in which we excluded mild and filmy adhesions. So the statistical methods used were all statistical calculations were carried out using the SPSS version 22. Data was statistically described in terms of mean plus minus standard deviation or median and range when not normally distributed, frequencies and relative frequencies when appropriate. For comparing categorical data, chi-square test was performed and ROC receiver operating characteristic curve analysis was done and the p-value was set to significant level at 0.05 level. So coming to the results, women who were selected were 360, out of which we excluded 240 women based on various causes. 5 women were excluded as they were known to have collagen diseases. 98 patients were excluded as they were undergoing their primary cesarean section. 129 underwent urgent cesarean section, so they were also excluded. And 8 women were excluded because they had previous surgeries other than cesarean sections. So we were left with 120 women who were eligible for our study and were evaluated by the sliding sign. Out of those, 54 women had negative sliding sign, that is, the adhesions were present. And we confirmed the presence of adhesions in 44 out of these 54 women on surgery. Whereas in 10 women, there were no adhesions to be found in surgery. Positive sliding sign was seen in 66 women, that is, there were no adhesions present on the ultrasound sliding sign, and we confirmed the absence of any adhesions in all of these women on surgery. So comparing the demographic, basic demographic data in these women, the mean maternal age was 26.7 years and the maternal age ranged from 20 to 40 years. The mean parity was 2.49 years, 2.49, and the parity ranged from 1 to 5. Previous cesarean section was present in 2.11 women. As regards to the previous cesarean section, 43 had previous 1 cesarean section, that is 36% women. 36 women had previous 2 cesarean sections. 28 women had previous 3 cesarean sections, and 13 had more than or equal to 4 cesarean sections. 20 patients had a preterm delivery due to medical disorders like preeclampsia, uncontrolled diabetes, which indicated a cesarean delivery, whereas maximum patients, 100 women out of 120, had a term delivery at more than or equal to 37 weeks. Comparing the BMI, the mean BMI was 29.37 plus minus 4.24, ranging from 19.7 to 44.4, with 44.2%, that is 53 out of 120 women being obese. There were statistically significant associations present between the presence or absence of intraoperative adhesions and maternal age group in years, with women more than 30 years old having a higher incidence than women with younger age. That is, 23 out of the 44 women who had adhesions were more than 30 years old, and 21 out of 44 women belong to a younger age group, which was a significant difference with a p-value of 0.001. This can be explained by the higher parity with increasing age and thus higher number of cesarean sections. Comparing the BMI, the obese women, that is women who are, they had 28 out of 44 women had a higher incidence of cesarean sections with a significant p-value of 0.004, whereas women with higher parity, that is more than or equal to 3 previous childbirths, had a higher incidence of cesarean section as compared to women with lower parity, with a p-value of 0.000, which was significant. Comparing the presence or absence of intraoperative adhesions and the number of previous cesarean sections, as the number of previous cesarean sections increased, the incidence of adhesions increased with the p-value of 0.000, which was significant. And comparing the gestational age in weeks, term deliveries had a higher incidence as compared to preterm deliveries. 31 out of 44 patients had term deliveries and 13 out of 44 patients had preterm deliveries. The p-value was significant enough and amounting to 0.004. There was no statistically significant association found between the presence or absence of intraoperative adhesions and the place of delivery, the p-value being 0.426, which is not significant. Examination of the sliding sign was successfully done in 120 women. Negative sliding sign was noted in 54 patients, and presence of intra-abdominal adhesions was confirmed in 44 out of the 54 patients. That is, on ultrasound, we found the adhesions to be present in 54 patients. That is, they had a negative sliding sign, but on surgery, only 44 patients were confirmed to have adhesions. Thus, the prevalence of moderate to severe adhesions was 36.6%. That is, 44 out of the total 120 patients were confirmed to have moderate to severe adhesions. Whereas positive sliding sign was noted in 66 patients, and the absence of moderate to severe intra-abdominal adhesions was confirmed in all 66 patients during surgery. The predictive ability of the sliding sign for detection of intra-abdominal adhesions in women with undergoing repeated cesarean section using the ROC curve analysis, the results are as follows. The area under the ROC curve was 0.934, sensitivity 100%, specificity of 86.84%, positive predictive value of 81.5%, negative predictive value of 100%, overall accuracy of 91.67%. The sliding sign was thus observed to be a significantly better predictor for the detection of intra-abdominal adhesions in women with repeated cesarean section delivery with a p-value of 0.001. While reviewing the literature, coming to the discussion, while reviewing the literature for methods of prediction of intra-abdominal adhesions during repeated cesarean section, 4 studies were concerned about the evaluation of the accuracy of the dynamic ultrasound sliding sign for prediction of intraperitoneal adhesions in women with repeated CS. The studies are Barron et al. In 2018, Drucker et al. In 2018, Booker and Shu. Comparing the results, mean maternal age in the present studies was lower than the other studies. It can be due to the early age of marriage in this community in which the study is being carried out. As we can see, comparing the present study with the based on the number of previous cesarean sections to the study conducted by Drucker and Barron, the study conducted by the results given by Drucker et al. Were in agreement with the present study based on the number of previous cesarean sections, and the study conducted by Barron. In this study, there was a higher rate of cesarean section than the present study, which can be due to a higher mean parity in this study. The comparing the BMI of the present study with Drucker, which was quite similar to the present study, comparing the prevalence of moderate and severe adhesions, the study conducted by Shu was in this study the lower prevalence than the present study. It can be due to the fact that most cases, about 90.1%, had only previous one cesarean section, according to Shu. Comparing the sensitivity and specificity, the sensitivity in present study is 100%, Booker 100%, Barron et al. 76.2%, Drucker et al. 56%, and the study by Shu, the sensitivity is 53.3%. The specificity of the present study is 86.84%. In the study by Booker, it was 100%, and Barron 92.1%. The strengths of the study are the novelty of the study, the study design, which was a blinded prospective design, and it is the first Egyptian study to assess the role of transabdominal scan in predicting adhesions in women with repeated cesarean section. The limitations of the study are there being a small sample size and presence of different surgeons performing the cesarean sections, which affects the judgment of severity of adhesions. And there can be other limitations also. While discussing with Dr. Parna, which we found was that the patients who had endometriosis or other inflammatory diseases like pelvic inflammatory diseases should also be excluded from the study because they also have a higher risk of adhesions. So coming to the conclusion, a preoperative transabdominal ultrasound to detect severe intra-abdominal adhesions has the advantage of simplicity. Predicting severe adhesions based on a negative sliding sign can result in better planning and safer conduction of the surgery. Also results in improved perioperative decision-making process concerning the time of surgery, surgeon seniority, anesthetic team, type of anesthesia, surgical technique, preparation of blood products, high level of care required in women suspected of having high intra-abdominal adhesions can also be decided upon before taking up the patient for surgery. Thank you.
Thank you, Dr. Sakshi. Wonderfully done. I request Dr. Aparna to give her inputs. Please stop sharing, Sakshi.
Yes.
Very good job, Sakshi. I think you did a great presentation. That was really good. I think whenever we're talking about a study, we have to look at it in two different ways, right? So one, was the study conducted well? Because before we blindly kind of accept any study's outcomes, you have to see. That's why I think I gave Sakshi some of the, I told Sakshi to talk about basics of cross-sectional design, what we're achieving out of it, how cross-sectional studies should be reported, which is like the strobe checklist. So as we do consult for randomized control trial for any observational studies, you have to think about some of the other checklists. So the study was conducted well, and I think if you look at the outcomes, and it's pretty much what we knew about. People who've had more C-section probably will have more adhesions, people who have like other things. So I was not like surprised by any of the things that I actually found in the study, but it was kind of a good way to look at a screening, as much as you want to call it, to see if there are going to be adhesions or not. But I think me and Sakshi, I had a phone call with her and we were talking about it. It's like, so what, right? So I think one of the questions you have to ask is, what's the clinical relevance of finding out adhesions before? I hope that all of the trainees who we're, training come out with the skills to do a C-section, whether there is like 1 prior, 2 prior, 3 prior C-sections with any amount of adhesions. And the more, I think it's more of a clinical judgment that you need to be ready to go into that operating room, whether there is a positive or a negative sliding sign, and be same careful about bowel, bladder, entry and everything. So to me, the practical utility of a screening test for adhesions seemed a little bit like, do we really need one? Do we need that extra step of looking for adhesions on that ultrasound? But if you do have a transabdominal ultrasound, and if you're anyway doing one, it may not hurt to see is the anterior abdominal wall stuck to if the uterus is stuck to the anterior abdominal wall, just so that maybe you are a little bit more careful in that entry. Although I would say whether there's positive or negative sliding scale, depending on how many sections or even 1 prior surgery, you always have to be careful in terms of like, the entry point or anything like that. So that's kind of where I kind of started. I was like, study is well conducted. The screening test seems like it's pretty valid in terms of the sensitivity and specificity that they got. The timing of like when to look for adhesions and all, like, will be interesting. But again, the clinical value of it. Like, would I do something different? Maybe in a place where there are not that many trained officers, like I think in parts of the world where community officers are doing C-sections, maybe not a good idea. Refer them to a place where there is an obstetrician who can actually take care of the stuff, or where there are patients, like people who can help you with the bowel injury or bladder injury, But this was more of the difficulty of the adhesions was more thinking in terms of entry and getting the baby out, and not really a bowel bladder injury type of a thing. But those are some of the things to keep in mind. But per se, I thought interesting, but clinically, would it change too much of what we do? Maybe not.
Thank you, Dr. Aparna. Dr. Ranjana, ma'am.
Yeah, actually, I was thinking that as a routine, we need not do this. But in some high-risk patients, like if the patient is very obese, if she's been treated for infertility, so and maybe if she gives a past history of tuberculosis, or she's had endometriosis and she's been done IVF and she's conceived that way, then those patients, it would be better if we go in and check for the additions. And sometimes it is so surprising that a patient with 3 previous cesareans, and you open the abdomen, it's absolutely clean, and there's no problem at all. So somehow I feel that some people, there is a tendency for addition formation, and in some, there's no addition formation despite 3 surgeries, 4 surgeries. I've even done up to 5th surgery, 5th cesarean. But of course, it was the 5th one was difficult. But otherwise, sometimes you don't get, and sometimes after 1 cesarean, previous one, and it's really bad when you open. So if you are prepared beforehand, it's always better, because then you make sure that the hemoglobin is correct and the blood products could be available if you need it. So that way, of course, it is clinically significant. But maybe not as a routine.
I think Charmila has logged out. I totally agree with you, Aparna. I personally see 2 issues with this. First of all, as you very rightly pointed out, that it may not be a great benefit. The only benefit I see is probably you are better prepared mentally when you are, taking an incision, that, you're dealing with a uterus which is stuck to the anterior abdominal wall. Because at times, when you don't anticipate it and when you start doing it, then you are, for a moment, you start shaking whether, where you are going or which plane are you operating. So this would be the only advantage. A flip side that I see is the person who is who's doing the scan has to be well versed with it.
Yes.
Because, then the reporting of this particular issue will have to be really done well, so that it will be helpful for the clinician, so that, when you start performing a C-section, that would be of great help.
Sorry, my connection went off for a
minute.
Yeah.
We saw that. That's why I just.
You're back.
Yeah, Kannagi ma'am, madam has given her inputs. Kannagi ma'am.
No, she has to give.
Yeah. So as rightly put by Aparna, we can't just be sending her for a scan to find out whether it's stuck or not. And then, it's not like, as you say, it's just a by the way finding. It can be. The only other thought, as she was going through the talk, I thought, if we listen the bladder, if we see her on a full bladder, we could see pick up those cases where it's highly drawn up, really high. I'm not saying the normal, very highly drawn up. So there, of course, you need a lot of help. You may need the urologist to help you out with whatever. That's very bad bladders being stuck. And as Dr. Padak said, sometimes you open and you don't know where you are, whether it's a rectal sheath or peritoneum or you go right into the amniotic fluid squirts. So those are kind of cases probably we can beware and do a higher incision or something like that. We can plan better.
Thank you so much, ma'am. Kavita, before we wrap it up, would you like to say something? Or your presenters would like to mention something?
Actually, my residents have really worked hard, and they had some rigorous practice sessions in the department also. So I'm really thankful, and it's really good to hear all the comments and the points that the national experts have given. For the last one, when I was making them practice on the department, I emphasized more on the clinical indicators where they should be well prepared for additions inside. So like the history, examination, everything is very important, particularly history, like any history of fever, sepsis earlier in the previous surgeries, the number of cesareans. And I said, when you are doing a primary cesarean also, you should be well prepared for any surprises. So it was like a part of learning that we were discussing this. And I think clinical judgment is more important than the ultrasound, the sliding sign. And as ma'am already has mentioned, that it should not be a routine.
Yeah. And a detailed history is very, very important. And we often overlook this point. We don't give that much time in taking a history. So,
one thing I found very strange here is where the first cesarean was done. Because if it's done elsewhere, we always say if it's done at a rural center or something, they expect addition. It's not so. So, I mean, we just shouldn't blame any center. It's rather the surgeon.
Of course.
But again, I feel like when you're looking at a study, you always have to think, is this going to make what I do different? And to me, I feel like I would still take a good history. I would still kind of keep in mind that regardless if it's a primary number 1, number 2, number 3, number 4, you go in with the same like thought, like, you know, you just try to avoid bowel and bladder. You try to go in, get the baby out, suture everything, come back. I feel like that probably won't change. But if you're putting a probe in anyway, or like if it's a really place where you don't have obstetrician and someone is doing it in parts of the world, maybe. But for us, I think we got to be careful. We got to be careful. And the difficult ones are going to be difficult no matter how much you prepped. But the availability of the blood products, availability of the expertise, maybe that's something that we need to think about. And I think one of the other things that was brought up where the study was done, how the study was picked and everything. I think being in different parts of the world now, I do think there is something to learn from studies that are done in any part of the, world, right? I know the population may be different. I know the thing is different, but once we cut, the tissue is the same color, the blood is the same color. I mean, here in the United States, my patients range from Egyptian to Indian to Chinese to, Vietnamese to you name it. I have every patient that I kind of operate on, that I work on. And sometimes when you kind of read these articles, when you kind of look at a journal club, the goal of the journal clubs and what we study is twofold, right? One is to comment on the validity of how they did it, what they did it, and then the clinical applicability. And no matter globally where things are done, there's something to learn from every study that we kind of look into. And the population may be different. As I said, I work with a very diverse population now that I'm in a center which is kind of very diverse, but there is the clinical consensus are somewhat similar, but there will be individual differences, there will be regional differences, there will be country differences, there'll be guideline differences. So you always have to be sensitive to that. And that's the part of learning. And you guys did a good job of presenting 3 diverse topics, OB, fertility, something that's good for everyone. And your residents, did a very good job of putting everything together. It must be very hard to present to a large group of people who can comment on anything, the experts and stuff. So I really give kudos to Dr. Kavita. Your residents were really good. So congratulations on a well-presented journal club.
My special thanks to Dr. Aparna. Actually, she's looking so fresh and
I know,
glowing in the morning. Thank you for joining.
Parag, would you like to say something before we? Yeah. Thank you, Dr. Aparna. Thank you so much. Parag, would you like to say something before we finish the session?
Yeah. So I think on behalf of ICOG, I would personally like to thank all our experts. Aparna, especially, thank you very much for being with us at this very early morning hours. Thank you, Dr. Ranjana. Thank you, Dr. Carnegie. Thank you, Dr. Reena, for your expert inputs. And Dr. Kavita, I must appreciate you and your students. They've done exceedingly well in making the presentation. And of course, I enjoyed the discussion too. And Chamila, you're the one behind all this. So a special word of appreciation to you.
Thank you so much, Parag. I would like to place my vote of thanks to the entire gathering now. A special thanks to Dr. Parag, the Vice Chair of ICOG, who has joined and has been with us throughout the program. Thank you so much for that. I'd like to thank the special guest, Dr. Mandakini Meg, ma'am, who's the brain behind this journal club when she started in 2020. I'd like to thank the international expert, Dr. Appana Sridhar, and you are fresh, so you're making us also feel fresh even in the evening. Thank you so much for that. And I would like to thank especially all the national experts who joined. Ranjana Kara ma'am, you add joy to any program. It can be an academic program or any of our other activities in FOGSI. Thank you so much for that.
Thank you.
Yeah, I'd like to thank Kannagi ma'am, who's joined from Coimbatore. I know she's extremely busy with the pickups now. I picked her up in the middle of her work and brought her inside the journal club. Thank you, Kannagi ma'am, for joining us.
Just making baby Paris women, OB Paris women.
Yeah. Thank you so much for joining. And I'd like to thank Dr. Reena Vani. And I would like to thank all the presenters who did such an excellent job, as Parag said. All were so lucid. Everything was so clear, and we could understand every point at every slide was so well done. Thank you so much for that. Dr. Nitika, both the Sakshi squared. Both of you did so well. The delegates were joined. I know it's a small number, but many will join in the recording and they see the recordings. They got a big footfall for that. And we are extremely popular as far as the website is concerned. Many join our program. I'd like to thank the ICOG team, especially Neelima, has put forth such a great program for us, and tech support, Jignesh, for all the support. Thank you so much for joining today. We'll meet again next month, second Tuesday. Yes, Parag?
Yes.
Thanks, Charmila, for putting together such a lovely program. You're the wind behind the wings.
Thank you, ma'am.
Yeah, we must acknowledge presence of past president of FOGSI, Dr. Rustam Soonawala. At his seniority, sir is there for most of the ICOG programs, and we really feel blessed to have him listening to us. Sir, thank you very much for your presence, and it really encourages us that seniors like you are with us in whatever little contribution that we all do.
Thank you so much, sir. Thank you, sir.
Thank you.
A big thank you from CMC for giving us this opportunity.
I forgot to thank Kavita, the brain behind the program. Thank you, Kavita, so much. And thank you. Yeah, thank you, Dimple, for your coordination. I'm sorry she was not there, but she had coordinated the entire CV collection and did all the program working for us. Thank you so much, Kavita and Dimple. Thank you.